Good morning. On behalf of our co-authors, I'd like to thank the organizers for inviting us to present our data. Before I start, I want to give you a few disclosures. So I have no disclosures relevant to this presentation. However, I am an infectious disease trained physician, not a pediatrician, Nutella. So this is for you. So any comments when I talk about infant prophylaxis, and as a way of background, this all came up last night, so I was getting fearful, so I ran back to my room and adjusted my slides. Please take out your cell phone, and I have provided you with the number to Dr. Lowenthal, who I work with at Children's Hospital, and she will answer all questions about how much nevirapine we use for infants. Thank you. All right, so with that as my disclosure and get rid of my fear factor, let's talk about the background. So you just heard the United States perinatal guidelines on infant feeding among women living with HIV were updated in January 2023 to support parental choice through shared decision-making, not a specific infant feeding mode. And now I have a picture to my left. Many questions exist regarding how best to support families who choose to breastfeed infants in the context of maternal HIV. And we do know, and we will hear, as we've heard through the day, there's no consensus on antiretroviral therapy prophylaxis for infants of individuals with sustained viral suppression who are breastfed. So the objective of our case series was to describe the breastfeeding population and their clinical outcomes in a large urban center in the U.S. to help inform others seeking to provide similar care. And secondary was to describe the situations that impacted clinical decisions and relevant outcomes. We conducted a retrospective chart review. It was done at Children's Hospital of Philadelphia Special Immunology Family Care Center. And just by way of backgrounds, there's 2 pediatric facilities in Philadelphia where HIV-exposed infants, as well as those who have acquired HIV, are referred to. And it's not just the site where I work as Adult ID, it's really a referral center. And interesting enough, when we went through the data, only one of the cases I'm going to present were actually from our clinic. So the inclusion was women with HIV and their infants. And please note the time period. So it was January 1st of 2018 through June 30th of 2023. So this really does not reflect the updated guidelines. This was all done prior to guideline change. So we did have people who chose to breastfeed, and we supported them through that prior to a guideline change. And inclusion any breastfeeding. We excluded one person who had in utero HIV acquisition. I know this is hard to see, and I'm going to quickly summarize. We only have 12, and it's kind of funny. I'm used to presenting data with, a couple hundred thousands, and here I'm presenting 12, and I'm standing up here doing an oral. But if you look, the median age was 30. Majority were Black, non-Hispanic. Interesting from this cohort, because it's different than what I see, majority were from the U.S., and you can see their relationship status. Most had public insurance, and most had not had perinatal HIV acquisition. Again, interesting demographics. Partner living with HIV, most were unknown. When you looked at disclosures in our cohort, most had actually disclosed to their partner, but they did not know their partner status. A wide range of regimens you can see here. They were on for anchor drugs and backbone. Interesting, there was one person on long-acting injectable cabrolpivirine, and all of them were on ART at the time of conception. So I'm going to go through a couple different pieces. We have lots of other data, but for 10 minutes I was only able to give you a short snippet. These were all pulled from medical records, so none of these were interviews. So what were the motivations for breastfeeding that this person chose? And we thought this was one of the most important highlights. I think most of us know the concern about the health and well-being of the child and bonding with their child. But some of the other ones that were pulled out that I had not even thought about. One person indicated she was concerned with the cost of formula, that she was not going to be able to afford it, and breastfeeding was an option that she would use. One person said it was culturally expected that she breastfed. And then the last one really tugged on the strings of my heart when I read it. And when I called Liz last night to tell her maybe calling her, she recalled this case very well as her patient. One person with perinatal HIV felt that her mental health issues were a direct relationship to the fear that her caregivers had when she was young, and she felt that poor early attachment had occurred because people were fearful of her, and she felt it was better for her to transmit HIV to her infant than to have those feelings that she had now, which is really, really impactful if you think about that. So Length of breastfeeding was all over the place, and we heard this last night when we had the discussion. It ranged from less than 1 day to 13 months. We had some patients who were very clear. They got to the point and they said, oh my God, I don't want anything to do with this. And you can see here, and we had 2 who went for more than 52 weeks, so it was really all over the place. And just to also let you know, we have continued to follow cases prospectively, so we're going to have prospective cases moving forward and hopefully collaborations with many others to have a large database to present at a later conference. Here were the virologic outcomes. So all women were suppressed at delivery. There were 2 cases of virologic failure, and I just want to walk you through each. And again, we were talking about the threshold. We set less than 50, a very strict threshold of less than 50. So for case 1, the viral load was 297 copies. That was 6 months into breastfeeding. There was a repeat 1 week later, and it was undetectable. And this person, as I said, breastfed. It was one of those long ones that breastfed for over a year. The last one was interesting. It was a viral load was 60 copies 5 months into breastfeeding. 1 month later, it was 261. And when I went back and questioned why was this person not stopped, what was the conversation, it was really the father had refused to switch to formula due to concerns that he felt formula was poisonous. He had a bad experience with a previous marriage with another baby and he would not let them switch. So the infant switched to triple therapy and remained on that through the duration of breastfeeding. Infant prophylaxis, so just in terms of background, so at CHOP, the recommended infant prophylaxis for someone who is breastfeeding, I listed here, it's sildenafil for the first 4 to 6 weeks of life, followed by daily nevirapine until 1 month after cessation of breastfeeding. And the reason this came about was a study led by Dr. Montplaisir, who's sitting right in the audience, looking at postpartum retention and care in Philadelphia area. And what she found, and please correct me if I'm wrong, at 90 days post-delivery, 38% were retained in care. And then at year, it was 38% at 1 year, and 31% were virally suppressed. So very low rates of suppression. So as a result, this was the guidelines that were recommended for prophylaxis. So you can see here, again, prophylaxis treatment were all over the place. Half of them receives adavudine only, half receives adavudine followed by the daily nevirapine. And then again, we mentioned those who had the viremia went on to triple therapy, and then when they went back to being suppressed, would go back to nevirapine. Good news is that they attempted monthly testing, but as a result, at the end, all were HIV PCR negative. So in conclusion, safe breastfeeding has been demonstrated in this and other small U.S. cohorts, no HIV transmissions and no safety abnormalities with ARV prophylaxis. Obviously, we need more research to clarify best practices for many things, including monitoring, infant prophylaxis, and support. So a few acknowledgements. So the staff at Children's Hospital who actually helped collect all this data, because just the barriers to get in through their system were pretty impossible. Also thank Liz Lowenthal for helping to navigate that very complicated process. Natella, this is for you, for your understanding of what happens in pediatric facilities in Philadelphia and infant prophylaxis, and please be easy during the question and answer period. I also want to acknowledge Cece, if you could stand up. So Cece has been really instrumental from the Well Project and has, Cece's gone on tour with myself and Liz, delivering lectures all over the Philadelphia and around the tri-state area, informing people of the updated guidelines and what's out there. And lastly, Jürgen, I could not forget you. Please, no, I don't want you to stand up. I just want to remind you that 4 years ago, Sharon Walmsley presented me at this conference when I was home right before the pandemic with the Most Supportive Man Award. So even though you did a great job with the debate, you can only get the runner-up. I still remain the most supportive. So thank you very much for your time.